This is an introduction to retinal vein occlusions. Vein occlusions are the most common retinal vascular problem after diabetic retinopathy. There are two major kinds of vein occlusions, and we'll go into each of these separately in this section. The two major kinds of branch vein occlusions are branch retinal vein occlusions or central retinal vein occlusions. Each of these have multiple subgroups, all with their own prognosis patterns, and we'll go into these in later sessions. But for this introductory, we'll first talk about branch vein occlusions and the two types, macular vein occlusions and a major vein occlusion. In patients with macular retinal vein occlusions, all of the hemorrhaging will be inside the arcades, either superiorly or inferiorly. One of the major clinical aspects to vein occlusions is that they will have a wedge-shaped pattern with the apex pointing towards the site of the vascular occlusion. In this gentleman, this is a photograph of the right eye, and in the macula you see some fairly dense intraretinal hemorrhaging in the superior macula and some just superior to the fovea. There are small reddish dots around the fovea, and these are probably small hemorrhages inside some cystoid macular edema. Also of note, in this particular photograph, you can see some white spots. They're superficial in the red hemorrhaging, and these are cotton wool spots. These are not exudates, too white. Exudates are yellow. These are cotton wool spots, which are infarctions of the nerve fiber layer. This is another superior macular branch vein occlusion, different patient, and here the hemorrhaging is quite noticeable, but it's not as dense as the first example. So you can have varying amounts of hemorrhaging depending on how severe the vein blockage is, but again, it's in the pattern, and the vein blockage is probably about a disc off of the nerve along the supratemporal arcade. And here's an example of a major branch vein occlusion. Again, this is the right eye. You see hemorrhaging in the inferior macula, but you also see hemorrhaging in the inferior mid-periphery as well. An arrow points to the site of the vascular occlusion. In the papillomacular bundle, the yellow arrow points to some yellowish, very discrete lesions, and these are hard exudates. This means the vein occlusion has been present for a while. The bright white are in the nerve fiber layer, and these are cotton wool spots. Systemic risk factors for branch retinal vein occlusions include hypertension, diabetes, cerebrovascular disease, and cardiovascular disease. Some population-based studies have indeed shown increased mortality both from myocardial infarctions and also strokes. The workup for patients with retinal vein occlusions can depend on the age of the patient. For the young patient, for sure you need to take a blood pressure in the office before the patient gets out of your examining chair. They also should have a cardiovascular workup. If the cardiovascular workup is negative, then you should go on to clotting studies and everything, and this should include a complete blood count, ProTime, PTT, cardiolipin, and the other tests that you see on the slide here. If it is an older patient, get a good cardiovascular history and for sure do a blood pressure in the office. If those are negative, then it is probably just secondary to age, and it is not going, you'll not find any great association with hematological pathology. And that's for the older patient, those over 60, 65 years of age. Just as with the branch retinal vein occlusions, which had two major differences, the macular or the major retinal vein, the central retinal vein occlusions can be divided into two types. The four-quadrant or the hemicentral retinal vein occlusion. With a hemi-CRVO, you will find the hemorrhaging either in the two inferior quadrants or the two superior quadrants. And even though it is not complete, the natural history and prognosis of hemicentral retinal vein occlusions much more closely follows that of a full central retinal vein than a branch vein occlusion. Here are 4 central retinal vein occlusions, all of varying degrees and with slightly different presentations. The upper left photograph is a central retinal vein occlusion of the left eye. The nerve may be slightly edematous. You don't see a great cup disc ratio. The disc margins are slightly blurred, but on this photograph that is a difficult call. But the veins are dilated and they are a bit tortuous. There are mild hemorrhages in all 4 quadrants. The upper right photograph is a wide field or a composite photograph, and you can see much more hemorrhaging in all 4 quadrants. You can actually see that the nerve is not swollen and there's a good about a 0.2 to 0.3 cup disc ratio. The bottom left photograph shows some dilated veins. The nerve is quite hyperemic, and again there are hemorrhages in all 4 quadrants. There's a fresh cotton wool spot at the 6 o'clock edge of the nerve. There are a few faint cotton wool spots along the infratemporal vessels, and there are also some older cotton wool spots in the papillomacular bundle halfway between the nerve and the fovea. The final picture is on the bottom right, and that is what we call a blood and thunder look, and that is a very serious central retinal vein occlusion which has a very ominous prognosis. Here's a clinical picture of a hemicentral retinal vein occlusion. The optic nerve is pink and sharp. There's about a 0.5 cup disc ratio. The superior vasculature looks very good. There is hemorrhaging both in the inferior macula, infratemporal periphery, inferior periphery, and infranasal periphery. So this is getting both of the inferior quadrants, and this here would be categorized as a hemicentral retinal vein occlusion of the right eye. And here is another example, just not quite as obvious, but again, you can see hemorrhages in the inferior nasal macula, infratemporal macula, inferior periphery, and if you look closely, there are also some hemorrhages nasally. There's one lonesome hemorrhage about 10 o'clock off the nerve, but I would still qualify this as the inferior hemi-CRVO. And if you look, there's the inferior vein does branch and go up towards 10 o'clock, so the occlusion is of that inferior vein at the level of the lamina cribrosa. The risk factors for central retinal vein occlusions is fairly similar to that of the branch vein occlusion. Here, though, more people have systemic hypertension, 50 to 70%, 25% have diabetes, and occasionally you will find some blood dyscrasias or changes in the serum viscosity. And we'll get into the workup on the next slide. So there are 2 major types of central retinal vein occlusions based on age. There's the regular central retinal vein occlusion and the central retinal vein occlusion of the young. And that's really important to know the difference between the 2. If the patient is over 60 and there are no systemic risk factors such as cardiovascular disease, hyperlipidemia, and diabetes, the only thing that I would have you do is be sure you check the blood pressure in the office, get a note back to the PCP, and follow the patient in about a month or so. If the patient is less than 55 years of age, even with a vein occlusion, a central retinal vein occlusion in one eye, that patient also needs a blood pressure in the office, but that patient will need a full hematological workup when they come in, just as we would do for branch vein occlusion, but I would not wait Even if they have hypertension, I would get the full hematological workup regardless of what you find in the office. So, in summary, branch retinal vein occlusions have hemorrhages that are generally wedge-shaped, and the apex of the wedge points towards the site of the vein occlusion. They can be macular or a major retinal vein. Central retinal veins can either be 2-quadrant or 4-quadrant. Every patient with a vein occlusion needs to have their blood pressure checked in the office before they get sent out. Even though vein occlusions are associated with hypertension, atherosclerosis, hyperlipidemia, and all that, you do a systemic workup as needed, whether the risk factors are known or especially if they are young patients.